Everyone. This is Maria Velasquez, and I'll go ahead and start clicking through the slides. Bear with me. Our goal today with the limited time and hope to make it a meaningful time for you is to go over what the blueprint for complex care is, introduce ourselves a little bit and give some background on ourselves and the National Center, discuss the blueprint findings, both as an assessment of the current state of complex care, but also discussing the blueprint recommendations, which is how we hope to advance the field of complex care. And then we truly hope to have some time for some Q&A at the end, but also we'll leave our information page if you have any questions moving forward. And I'll pass it over to Mark to introduce himself.
Hello, everyone. Really grateful for this opportunity to be with you today. My name is Mark Humowiecki, and I'm the Senior Director of the National Center. And the National Center is housed at the Camden Coalition of Healthcare Providers, and was created 3 years ago to really help catalyze a field of complex care. And we, as a center, seek to convene, inspire, and support all the myriad stakeholders who are involved in the emerging field of complex care through events, publications and resources, and technical assistance and training. And we are very proud to be here today talking about the Blueprint for Complex Care, which we developed in partnership with Center for Healthcare Strategies and IHI. I will turn it back to Maria.
Thank you, Mark. Good afternoon, everyone. This is Maria Velasquez. Like I said, I'm the Senior Program Manager of National Partnerships here at the National Center for Complex Health and Social Needs, an initiative out of the Camden Coalition of Healthcare Providers. Like Mark said, I'm extremely excited to be here. One of my great roles here at the Coalition is to help strategize our partnerships moving forward, and we are very cognizant of the need to meaningfully partner with representatives from the field. And so we appreciate being able to talk to you from a payer perspective. I'll quickly go into our blueprint. And what is the blueprint? And we'll talk more in depth, but essentially it was launched right around the time that the National Center was launched. And at that time, our charge was really to become a professional home for those in the field and to help catalyze the development of this new field of practice. So we essentially did an environmental scan and looked around and saw that there were many different organizations contributing to the field, but they were doing so in a very uncoordinated fashion and continue to do so. And so our challenge now is to help define terms, frameworks, and goals for the field. When we did the scan, we also saw a tremendous passion and energy from a very small but growing community. And so we're starting to see some exciting developments that look as if they could really accelerate the progress. So things like the creation of the Six Foundation Collaborative, the launch of the playbook, the National Academy of Medicine report on effective care for high needs patients. And so the blueprint sets out to really build on this growing body of work and to tap directly into this passion and insight of the community to help identify its path forward. We really chose to create a multi-organizational leadership process to develop this blueprint, and that came from recognizing that the field is being built by many players, and the complex care work itself requires a great collaboration. And we're privileged to work with CHCS and IHI, both of whom we all know have been leaders in the development of complex care. And so in this case, our work together on this project has really generated a tremendous learning and trust. And so our goals for the blueprint were both to assess the current state of the field, including documenting areas of consensus. We also want to learn from parallel but more mature and structured fields like hospital medicine, palliative care, and geriatrics to best understand the pathways and strategies that they use to strengthen and spread their practices. And then we also to develop scientific, concrete recommendations to advance the field over the next 3 to 5 years, which we'll talk a little bit about throughout the presentation. We really hope to be much more intentional, both in the blueprint and in the sort of dissemination of the blueprint about the development of the field, so we can create greater consistency and coordination amongst all of those that are contributing to the development. And pass it over to Mark.
Great. Thanks, Maria. So one of the goals of the blueprint process was to document our current state, including creating some more shared definitions of key terms and concepts. And this slide represents a consensus definition of complex care. And there are actually a couple of different descriptions of what complex care is and seeks to do. But this one has a couple of key components to it. So one is talking about the population. And the population is characterized by extreme healthcare utilization and cost. The population is also characterized by root causes that go beyond pure medical conditions to include some combination of medical, behavioral health, and social needs. And complex care is really trying to address the fact that healthcare and social care in our country tends to be very siloed and has a lot of barriers to integration that leads to the sort of inefficiency and leads to the heavy utilization among a small population, and that we need to address those silos and fragmentation within those systems in order to really meet the needs of people with complex needs. So on the right is a visual of a complex care ecosystem, and this is the sort of term we're using to describe the way in which in local communities you need to be able to collaborate. So while complex care management programs work at the level of the individual patient to try to knit together services that are necessary across multiple providers, to really advance the field and advance sort of the system for people with complex needs, we need to be striving to create these sorts of ecosystems where collaboration is the norm between all the different sort of participants in the delivery system. And that's whether that's housing, home care, pharmacy, behavioral health, you can see sort of around the ecosystem. And of course, payers are a major part of this ecosystem and play a significant role in helping to try to forge the ecosystems and the relationships among them, because it's the reimbursement and the payment that allows for people to do the work on behalf of this population. We also found, as part of our sort of discussion of what complex care is and what differentiates it from other fields, that it's a bridging field. It doesn't seek to replace or compete with other fields. It doesn't seek to replace primary care or mental health or addiction medicine. Instead, it's trying to borrow and bridge the knowledge of practices of the different fields.
Oh, Mark, I think we lost you there for a bit.
Oh, I apologize. So, as I was saying, that we've described the complex care field as a bridging field, one in which we're really trying to take the best ideas and practices that pertain to people with significant needs and knit them together. So it embraces other fields like mental health and addiction medicine and palliative care, rather than trying to be an exclusive specialty field.
Great.
Back to you, Maria.
Thanks. So like Mark just highlighted, complex care really operates both at the personal and systems level. Personal because we understand that it's by coordinating care for individuals in a meaningful way. At the systems level, by creating complex care ecosystems like Mark just went over, which are just local networks of organizations that collaborate to serve individuals with complex health and social needs. So really at its heart, complex care seeks to be person-centered, equitable, cross-sector, team-based, and data-driven. And through all of the research, we identified essentially 5 core principles of complex care. One being that, like I said, it's person-centered. The programs are designed around individual needs and preferences, and the needs of the whole person are addressed. So given the high rate of childhood and adult trauma among this population, services must be delivered in a trauma-informed way, which is also discussed on the blueprint. Equitable, that complex care recognizes that individuals often face needs that are the result of systemic inequalities and disproportionalities like poverty and structural racism. And the field also values the wisdom and expertise of those with lived experience. And so that's what we mean by equitable. And team-based, Because we know that the needs are highly heterogeneous and span various professions, it's very important for us that the care teams are multidisciplinary. And furthermore, that the teams must meaningfully include both the patient, but also family, loved ones, and their support or kin networks. Cross-sector, that as you see in the ecosystem graphic, the needs span traditional sector boundaries as we know them, and they really require stakeholders to collaborate in a new and innovative way. And we're certainly data-driven. We like encourage using cross-sector data to identify the most complex patients to improve performance and better evaluate outcomes. And back to you, Mark.
So the blueprint was developed over essentially a 15-month process. It launched with some planning in the fall of 2017, and at our conference in Los Angeles in November of 2017 was the sort of first public discussion of the blueprint. And at that conference, we called on participants to provide input through polls and through interactive activities. Folks actually did arts and crafts to design their own complex care house and identify who the most essential stakeholders were and what the values were. And we continued on in that way over the course of the year to really try to meaningfully and creatively engage folks in the community of complex care to understand how they view themselves, how they describe the work that they're doing, what their values are, what they're proud of, but also what their pain points are, and how they think the field needs to advance. So following that sort of public launch and interactive process at our conference, we set about doing a fairly comprehensive literature scan and review of both published and gray literature. We did a semi-structured interview process with several dozen complex care providers, also folks from the payer community, people with lived experience, researchers, trying to, again, get at the heart of where is the field now, where does it need to go. Using all that information, we brought together a group of about 20 to 25 experts at a 2-day convening, really presented those, got feedback, discussed the various options for recommendations. That was the third phase in the spring of 2018. And then we set about drafting the report, and that was a fairly interactive process where among the 3 organizations, as well as in consultation with the group of 6 foundation funders, as well as an array of experts that we've amassed over the years, including our advisory committee, we set about testing out the ideas and the concepts and the definitions until we got to a point where it was really ready to go. And then we had several outside experts that did a final sort of peer review of the report, and we released it at our conference in Chicago a year later in December. And so now we're in the sort of final phase. It's not really reflected on this this slide, but we're in that dissemination and activation phase where we're trying to get out to organizations and groups like yours that are really significant stakeholders and have a role to play and that you have been playing in the development of the field. And then we're also seeking now to try to activate new projects that directly go to implement some of the recommendations that we'll talk about towards the end. So the next slide gives you just a little bit of the blueprint by the numbers. As I said, one of our sort of underlying principles and sort of philosophy about how this blueprint should be developed, we did not want it to be a small number of self-appointed experts from on high telling the field what it needed. We really wanted it to be reflective of what the field itself thinks and experiences, on a day-to-day basis. And we were very intentional in seeking out stakeholders to be talking to people not only that have been sort of the forerunners of the field, but also folks that are doing this work for the first time now. And to talk to folks at all levels, from health system leaders and payer leaders to community health workers and family caregivers. So we really tried to get a diversity of opinions across profession, geography, role, race, gender, you name it. We really wanted to reflect the breadth of the field. And so here are just a few of the numbers. The 140 are the people that were participated in making those houses at our first conference. The 108 report, studies, and other literature that were ultimately reviewed and cited in the report. 45 complex care practitioners that were either interviewed or participated in our expert convening. Throughout the process, we did a number of surveys because we knew that there were more people that wanted to give input than we could interview directly. And so the questions we were asking through the interview process, people completed as surveys. We were really impressed. Folks would spend on average 15 to 20 minutes completing these surveys and giving us really robust feedback on what they see as most critical to the field. And then, as Maria suggested, part of the goal of this was not just to look inward at our own field, but to look outward at other fields that have sort of traced a path from innovation to standard of care, and to try to learn from them what their key lessons were and avoid some of their mistakes. So we had the pleasure of interviewing 6 real field builders from some of those different fields, including folks like Diane Meyer from palliative care. So next slide. As we started the project, we had this sort of clunky metaphor of a blueprint. We were thinking homes. Sometimes we were talking about neighborhoods. We gave people paper to draw their own houses, and we were really, on the verge of just ruining this metaphor, trying to figure out what the different rooms of the house would be, from research to policy to payment, etc. When fortunately we found the strong field framework to save us from ourselves. The strong field framework was developed by the Bridgespan Group, which provides management consulting and strategic support to nonprofit organizations looking to have a social impact. And this is something they had developed actually close to a decade ago, based on examining the development of dozens of social impact fields and looking at sort of the common elements. And we found as a steering committee that the strong field framework really captures all the components of what we thought of as a field. And so we set about using this framework, and the expert convening really endorsed it. So that's the organizing principle that you'll see throughout the report. So the first notion that was really appealing to us, because we had a lot of discussions about what it even means to be a field, a field of science, a field of medicine, of healthcare. Where exactly does complex care sit? The definition for field that the strong field framework uses is that it's a community of individuals and organizations with a common goal and agreed upon set of tools and practices to achieve that goal. And that felt right, that we were a small but mighty and growing community that wanted to reshape how services were delivered to people with the most complex needs, and that our goal was to continue to standardize and perfect those practices and structures for being able to serve that population, and that was the most useful definition of field. And so within a field, there's these 5 domains. The first sits on top because it really defines the community itself. It's a shared identity. Is the community aligned around a common purpose and a set of core values? The second is standards of practice, and this gets into all the components of the practice of complex care, agreeing on standards, structuring practice through evidence-based models, resources for training of individuals, and for implementation of models and programs. The third domain is knowledge base. What evidence do we have that the practices work? What structures and researchers do we have in place to continue to develop knowledge so that we can be continuously improving on those models and practices? And what are the structures for dissemination of knowledge so that the knowledge to practice loop can be tightened and practice can be advanced more quickly? The fourth is leadership and grassroots support. This is really the influence of the field. Do we have the influence to be able to affect the broader institutional landscape that we sit in, and does leadership and institutions leading the field enjoy popular support? And finally, funding and supporting policy gets at whether we have a payment and regulatory environment that's necessary in order to support and sustain the implementation of evidence-based practice. So I'm going to quickly try to go through over the next few slides an assessment of the field based on the literature review, interviews, surveys, and expert convening. We summarize both the strengths and the weaknesses in each domain of the Strong Field framework. And this is tries to really get the highest points, the most salient, most important notes that we heard. It's not designed to be completely comprehensive on every component of each of the domains, but rather to hit the highlights of what we heard from the community. And not surprising, there were very few unmitigated strengths or weaknesses. As an emerging field, we found that many of the factors that were strengths that the field was building on, but also that there were ways to go. So the strengths, weaknesses, sort of polarity isn't hard and fast, and many of these strengths have a weakness component and vice versa. So the first one is around shared identity, and I think this was something that we were really heartened by the fact that within probably a dozen of these interviews, we started to reach saturation on questions of what are the problems that complex care seeks to solve. Things like the inability to deal with social determinants of health, a lack of person-centeredness in our healthcare system, issues around fragmentation. So people agree on the problems, and they also agreed on the principles. Those 5 principles that Maria reviewed earlier pretty quickly came to consensus on those. And people also felt like the potential community of stakeholders is vast and diverse. We recognize a lot of people are doing complex care without calling it complex care. And it's, I think, probably one of Maria's greatest, and certainly one of my greatest joys, is to come across people who have that experience of saying, oh, wow, this is the term to describe what we're doing. This is a community of other people that are also doing it. I felt so alone in my work, and it's great to have this sort of community support. We see that experience time and time again in our conference and on office hours and other places where people have found a community, and that's really empowering and feels supportive. On the weakness side, on shared identity, I think the field definitely noted a lack of shared language, and the blueprint tried to set out to address that. Certainly does not solve that problem, but take some important steps towards creating some more shared language. And same thing about the confusion on who constitutes the target population. Next slide. So in terms of the standards of practice, I think there was a sense that we've been progressing in terms of having more and more models and pilots that are having positive evaluations, that are showing real return on investment, that promising practices exist and are spreading, and that there's been an effort among researchers and others. Maria mentioned the National Academies of Medicine report. There's some really great work that was done as part of that to build taxonomies, both of the population, but also of the models and practices that have been identified. So what are the core elements of an effective complex care program, and how are those achieved? On the weakness side, people recognize as a principle that we need to be data-driven, that data is critical to finding the population and serving them more effectively, but we also encounter in our day-to-day work limitations to data sharing, particularly when you go outside the sort of claims and EMR data that's available to the healthcare systems and are trying to incorporate social determinants data, behavioral health data, and other things, both because of technical challenges, legal challenges, as well as cultural challenges to that data sharing. And then we know there are workforce issues, that there's a shortage of providers prepared to deliver complex care, both because there's a shortage of providers in some of the core areas like primary care and behavioral health, but also because the training systems that are producing new providers haven't fully embraced all the practices that go along with complex care. And so folks are coming out not always ready to work with the most vulnerable populations, and there's additional continuing education that's needed to develop true complex care practitioners. The next area in terms of knowledge base, I think there's a growing body of literature around importance of addressing complex needs and the effectiveness of programs. Again, we're getting better at identifying people with complex needs and segmenting them into subpopulations. There's a developing community of researchers. I think it's noteworthy that Academy Health is going to have a complex care track at this year's conference. So this is coming into prominence not just among practitioners and philanthropy, but also among the research community. On the weakness side, we know that there's a problem in terms of measurement, that the measures that we typically use for population health aren't necessarily well tailored to the most complex populations, and that a lot of the measures that are focused on when talking about complex care and people with complex needs are limited to cost and utilization, and that the value of these programs, while reflected in cost and utilization, also go well beyond that in terms of improved health and well-being, as well as their impact, the impact not just on the healthcare system, but on other systems that these people touch. And there's also a whole debate around the type of evaluation that's necessary to establish the effectiveness of programs. Do we need to run series after series of randomized control trials, or is the field better served by more flexible, iterative, quality improvement types of evaluation that allow us to move more quickly? And I think there's an ongoing debate about this, and there's that's a healthy debate, and that there's a mix of different methods, and that will continue to be the case. In terms of leadership and grassroots support, I think the field has enjoyed being a high and growing priority for many healthcare payers, providers, policymakers, and philanthropy. We recognize also that there are some influential stakeholders in key segments of the field that have helped to increase buy-in, and we need to leverage those relationships and that sort of thought leadership. On the weakness side, we know as a principle that people with lived experience need to be at the forefront, need to be an equal partner in developing the field and designing solutions, and yet too often they're not given a seat at the table. I think this field, more so than many others, is trying to create creative ways to bring people with lived experience, both patients and caregivers, to the table, but a lot more needs to be done there. And then in terms of cross-sector partnership, again, it is the absolute essential component of this work, and yet living that out day to day can be challenging. And so there's more work that needs to be done in terms of doing true cross-sector collaboration, from culture, financial, data, and as well as sort of organizational structures and leadership. Finally, on the payment side and the policy side, we know that complex care's appeal comes from a shifting payment environment where providers assume accountability and greater financial risk. The continued acceleration of value-based payment raises the interest in the field and has engaged more systems in making investments. And there's been a lot of public investment over the last 5 to 8 years, and through programs like CMMI, through state Medicaid waiver programs and other initiatives to figure out how to better serve the population. And that's translating into private initiatives as well, whether it's through philanthropy or payer-led initiatives that are investing in these programs. Obviously, one of the goals is to create more flexibility to be able to pay for non-traditional costs and be able to bridge the sort of funding streams that typically pay for social care, behavioral health services, and medical care to be able to integrate those for individuals. On the weakness side, we know that in this shifting landscape, that there can be competing incentives, and that can be a challenge for systems trying to grow pilot programs into sustainable, scaled programs within their systems, and that the lack of the differences in funding between the different sectors, while we're trying to bridge them, remains a challenge. So that was the assessment. Lots of detail if you go into the 60-page report, but that's really the high level. Now I want to turn to the blueprint recommendations, which are 11 recommendations based on what we heard from the community, from the interviews and surveys and those working in the field for years. I don't have time to go through all the recommendations today. I'm going to highlight just a couple of them. Really, I could go through any one of them because they're each really important. We couldn't narrow them down to 10, so we kept 11. I'm going to give you a second to look them over right now, and then I'll go through just 3 of them quickly, and I want to make sure we have plenty of time for conversation. So the next slide really tries to crosswalk those recommendations against the components of the field, and you'll see that while some of the recommendations speak very not narrowly, but speak to one of the domains of the strong field framework, there are some that speak across domains. And we really tried to tailor the recommendations to the weaknesses that we called out in the overall assessment. So next page. The first recommendation is to develop core competencies and practical tools to support their use. This really goes to the workforce issues that I was describing in the standards of practice section. We recognize that really doing effective complex care requires a level of teamwork and a level of person-centeredness that is not, unfortunately, as standard as we'd like it to be. And the attention to trauma and the attention to social determinants issues, while gaining increasing popularity and certainly getting a lot more discussion these days, the skills of doing that work are hard fought and hard won. And so we really need to develop robust training programs that enable people who maybe have been operating in a more general healthcare environment, or working with a more general population to be better served to work with folks with the most complex needs. So the core competency recommendation is really to bring together an expert group that would include people from a variety of roles, in different professions, including people with lived experience, to really define what is essential to the practice of complex care at each of the different roles within a complex care team. We want to incorporate the good work that's been done of defining other core competencies, not recreate the wheel, but really define what's essential to complex care. Certainly we'll be pulling on the IPEC standards for interprofessional practice, but other core competencies that have been developed as well. And then the goal is really to take those core competencies and turn them into actionable training programs, certification programs, so that people can gain their expertise and really build out a workforce. So there's an open debate as to whether or not this is a specialty area that needs to come with specialty certification and licensure, and we have not made a decision on that, but really identifying the core competencies is the first step towards moving towards robust training. Next recommendation is around quality measurement, and something that I think comes up in almost every conversation we have with people in the field. There's a desire for more standardized measurements and more appropriate measurements. When you're working with people with that are facing homelessness and addiction, people who are going in and out of the emergency room, some of the clinical measurements that are used more generally for population health just don't get at what it takes to make progress with that population. So the recommendation here is to really think about both process and outcome measurements that show the quality and effectiveness of good complex care, to work towards aligning around standardized measures that reflect those values, and to reduce the burden of measurement on both on everyone involved in the system, to match measures to goals, and to move beyond measures that are limited to cost and utilization to really get at things like wellness and health and so forth. The last recommendation, or no, have one more, but the field of the leadership of people with lived experience really is that as a core principle of what complex care is. And while we think that our field is doing better than many, we know that there's a long way to go. So in any of the projects, any of the committees that will be developed to help advance, whether it's quality measurement or core competencies, we know we need to have people with lived experience at the table, not as tokens, but as meaningful contributors. We did our best throughout the blueprint process to engage folks with lived experience as part of the expert convening, as part of the interviews, but we know we need to create more seats for them. We need to have them be in teaching modes more often. So much of what the care teams learn, they learn from their patients, from their experience, in terms of what the barriers are and what's effective in helping folks. And so we need to bring that mindset to the development of the field. And then finally, the last recommendation that I'm highlighting today is around alternative payment models and just the sustainable payment for these programs. I think this was, again, probably the number one or number two most commonly cited issue, particularly for folks in the delivery systems. There's been a lot of investments in pilot programs, but often frustration about the inability to scale those programs because of lack of suitable payment models. And we know that the field can't grow to its full potential without sustainable funding. We know there's a lot of innovation going on right now in terms of those different payment models. And so the recommendations under this 9th set of recommendations, there are actually many sub-recommendations that get at things like establishing the business case for complex care, documenting promising payment models, greater collaboration with payers in terms of designing both the delivery system, but as well as the measurement and the payment structures. Also, because community organizations and behavioral health need to be at the table and really part of the solution, we need to develop more resources for them to improve their capacity to contract and to share data and be part of the healthcare delivery system. And finally, there may need to be billing codes to support these models as we transition from fee-for-service to fully value-based payment. So I will stop there and hand it back to Maria to talk about where we're going next with the blueprint.
Thanks, Mark. And one of the things I wanted to refer back to you if you'd like to update us on the most updated version of how we hope to prioritize recommendations for initial focus. One of the things that we realize is there are a lot of recommendations and sub-recommendations under that. And so our goal really is to prioritize these recommendations and establish mechanisms for actual coordinated action and in a very sort of tangible and attainable way. And so I didn't know if you want to quickly speak to how we are
Sure.
prioritizing some of those.
Yeah, I mean, I think we've got a number of different projects getting underway, but one that we expect to announce over the summer would be an expert group working on core competencies, and we'll be putting that out as an open call for submissions of or nominations of people to serve on an expert working panel to help define core competencies. So, that's one thing that we're actively working on. There's a lot around the business case that we have planned for this year. We're hoping IHI will help lead some coordinated work around quality measurement. So a number of these recommendations are getting new projects developed as we speak. And we're also just very much aware that there are active projects going on right now. Nonprofit Finance Fund is working on a project that's geared towards building the capacity of CBOs to contract with payers in healthcare. We see that as critical work to that ninth recommendation. So there's a lot going on, and part of our role as the National Center is to try to work with the philanthropy community to make key investments in strengthening the field.
Yes, and certainly the third point we are doing right now, and we hope to continue doing. And so not only do we appreciate you giving us this platform to share about the work, but also encourage you to please keep us in mind if you feel that there are other stakeholders and partners nationally that could both partner with us in sort of disseminating the blueprint and catalyzing the collective action, but could also perhaps benefit from learning more about the blueprint as well. In the meantime, some of the immediate ways to contribute is certainly to provide feedback on the blueprint. Although the form or the blueprint itself has been released, we are constantly receiving feedback on the blueprint for it to inform some of the working groups that we are going to convene moving forward. And so please use that as an opportunity. The second is to participate in some of these blueprint activities that Mark just mentioned, both to apply to be in these sort of more formal structures, but also to participate in any of the office hours or networking sessions, as you are doing today, to learn more about it. And the third and really a very efficient way of supporting it and endorsing it and sharing it with your constituents is to sign up to become a complex care champion. And essentially, as complex care champions, we are mainly just asking you to share that you both support the blueprint findings and recommendations, and that you are committed to sort of catalyze the collective action together. And so these are some of the leading organizations that have become complex care champions. There are organizations both in healthcare innovation, policy, and in delivery from across the country. And they just confirm their support as champions, and by doing so, confirm their interest in playing a role in advancing the field. There are also a number of resources for continuous learning, apart from some of these very tangible ways of becoming involved. You can sign up for our ongoing updates at the National Center for Complex Health and Social Needs. We can also invite you to sign up for Center for Healthcare Strategies. Obviously, the Better Care Playbook is another way of assessing the needs in the field, and this week at IHI. But that is about it on our end. We want to make sure that we have room for questions, and also if you'd like for us to go back to any slides and go deeper into any of the content, we are happy to do so as well. Mark, did you want to add anything to these last couple of slides before we open up for questions?
No, I think let's get into some conversation.
Yeah, same.
Great. So this is Lisa. Once again, thank you so much for a wonderful presentation on really very detailed information that I think is consistent with a lot of the way that our members are thinking about moving forward the field of complex care, but this provides a structure that I think is very helpful. One question that did come up was what your real working definition is of complex care. I mean, there are many, many components, and I don't want to hold you to some artificial, oversimplistic definition, but I guess it might be helpful to have that as a sort of basic context.
Well, I think, the definition that we included on that slide, which talks about improving the health and well-being of a relatively small heterogeneous group of people who repeatedly cycle through multiple healthcare, social service, and other systems, but do not derive lasting benefit. That's one of our core definitions. It gets at who the population is. It gets at the goals, which is really improving health and well-being. And it gets at that issue of the silo that exists between our different structures. So I think that paired with the principles in terms of complex care to really be effective needs to be person-centered, equitable, cross-sector, team-based, and data-driven. It is an umbrella. It includes very disparate models that can go from serving people with, like an aging adult population with chronic illness and social isolation through robust, nurse-led care management and intervention in the home, to a multi-discipline intensive, we often call them a ICU, sort of ambulatory ICU model, that's got a mix of primary care and specialty behavioral health and addiction services that are serving, a population that is characterized by behavioral health needs, as well as heavy utilization, and lots of other models as well. So I think it's not about a single model. It's about a set of practices and principles and focusing on the population that's the most vulnerable. I hope that's helpful.
Yeah, it is, absolutely. Thank you. So let's open it up just to the folks that are on the line. I'm happy to ask more questions, but I certainly want to open it up.
Hi, Pano Yarakaris in Rhode Island, which we are overseeing our statewide community health team network, multi-payer network, and a number of this. This is great, very thoughtful and helpful. Just one specific area is what work has been. I know you talked about maybe IHI doing something around quality measures. We have a evaluation through our SIM program that's looked at some quality of life measures, and I wonder what you're finding in terms of, is there a standard out there that folks are looking at, especially if you're starting to think of pay for success models, where that might be one of the components?
Yeah, I think it's a great question, and I think there is a lot of different work going on out there. I think one of the areas that people are really interested in is patient-reported outcomes and patient goal-driven outcomes, and that presents certain challenges. But I think in terms of the idea of measuring what matters to folks, that is sort of a core component. So we're settling on singular measures that everyone can use. I think that's part of where we need to get to. And there's a lot of good work on starting to define that question of quality of life or perceived improvement, both in terms of health and well-being. I know within the Camden Coalition, we've been using measures like healthy days, but we're starting to look at other measures of health and well-being that are patient-reported, that capture even more than that. So I think more to come there for sure.
Thank you.
Hi, Lisa. Stephen Peskin, I have a question.
Yeah, go ahead, Stephen. Stephen is with Horizon Blue Cross Blue Shield of New Jersey.
So I give a quick thumbnail case example. 65-year-old I visited yesterday, Mr. Michael, I won't use his last name, quadriplegic from MS, way smarter than me, physicist, used to bike 100 miles, now has zero activities of daily living, and we were talking about really smart guy, so maybe on the pure intellect spectrum, a bit more than most or many of our complex, chronically medically ill type patients that we might think about who are nearly homeless or homeless. So the consumer effort, even with his brilliance and ability to use a SIP-PUF device and send emails remarkably and talk on the phone, is really hard. So, I mean, for him to navigate the system, and I try to help him as best I can, knowing a little bit about health insurance and the healthcare system in New Jersey. So wondering how you're looking at this whole notion of consumer effort.
Stephen, it's a great question. I want to make sure I understand it. I mean, I think are you asking about how to involve people like the gentleman you were referring to who has
how to just make it easier for, I mean, again, I can take another example from my limited clinical practice, a chronically mentally ill person with frostbite on his feet and rather obstreperous and difficult. And so that's even more difficult when you have a person who's maybe unwilling to engage or has certain psychological barriers. But this is a really smart guy who is frustrated with the system. So my question is how Center for Healthcare Strategies, IHI, and the National Center for Complex Health and Social Needs is thinking about that aspect of it.
Yeah, no, it's a great question, and I think one of the things that we have done both as a national center, but also as an organization in Camden at the Camden Coalition, is to bring individuals who have lived experience, who have faced these complex needs into our governing bodies. So in Camden, we have a community advisory committee, and a lot of the patients that we've served through our complex care management program, as they graduate, go on to that community advisory council. One of them, who is the chair or the vice chair of our community advisory council, also sits on our board of directors. And just last week, we had a board meeting at which he was talking about his experience of having been homeless, having been addicted, really being suicidal and on the verge of ending his own life when he encountered the care management team and really has been able to recover in enormous ways and is now actively working as a peer to support others. And he actually said that the HIE saved my life. And it was the first time that I've ever heard someone say that, but he meant it. It was really, these folks often are completely invisible to our system, even though they may be in our system a ton. Really thoughtful ways of engaging them and getting them all the services that they need are few and far between. And that's really what complex care is seeking to do. And it's amazing the resilience of humans to be able to, when given those services, when engaged by someone who really shows that they care, forges an authentic healing relationship, the power of people to be able to recover and engage. And then once sort of in that role, their ability to give back, their desire to give back and to contribute to an organization, to a field, is numerous. So one of our advisors for our National Advisor Committee sounds like the first gentleman that you described, really brilliant policy analyst, in a wheelchair, quadriplegic, and he is lucky to live in Massachusetts and have a couple of PCAs that help him get around and navigate the system. And he does national speaking, and he is heavily involved in trying to make sure that the experience of people with complex needs are being adequately reflected in how this work gets built out. And he's the first to sort of admit that he doesn't face nearly the challenges that someone else would, because he is a white man with access to income and other privileges that, as you described, many of our complex patients don't have. So I think going into the community, going into the home are some of the core components of complex care that get at that isolation, but really being thoughtful about engaging people that can and want to contribute is essential for us to succeed.
Thank you. So we are just about out of time. There's just a few moments left. Are there any other questions? I just have one sort of pitch to make. I mean, obviously, this group of people on the multi-state collaborative webinars are generally associated with payer organizations supporting the work of primary care practices, and dealing with complex patients obviously is a huge part of their daily work. So as this is really just sort of tossing it out to the group to think about how best to try to incorporate some of the knowledge that is certainly part of the blueprint and all the work that's gone into it, and really look forward to having other opportunities to make connections there, because I think there's a great deal of synergy potentially there. So with that, I want to thank our presenters, Maria and Mark, for a really wonderful description of the blueprint, both in terms of its development and what can be done with it moving forward. And we look forward to seeing more things in the future from your team and to connecting in the future. Thank you very much.
Thank you for having us. We appreciate it.
Yeah, thank you, Lisa, and thank you, everyone.
Thank you.
Thanks.
Thank you.
Excellent presentation. Bye.
Thank you. Goodbye.